Good afternoon, and thank you for joining us. I am Denise Klingner. I'm representing the Benji Brooks Committee. You see a number of individuals were on the little subcommittee to come up with this particular topic, which we thought was quite important for all surgeons, no matter age or level of training. None of us have any particular financial relationships. So this is a photo of my little knitting corner. And you're like, wow, what does that have to do with ergonomics? Well, a friend of mine told me, hey, if you do all that repetitive stuff, you're not going to be able to be a surgeon. I'm like, how can I give up one or the other? So I looked into it, and there is a whole book on knitting ergonomics. I haven't read it all, but it exists, right? And this particular chair was designed in the 1950s to have a little cutout for your arms to be back. And it leans you back just a little bit so that your neck is in good position. I'm like, we don't have that in the OR, do we? No. The only downside I would say is that it comes from Europe, and it arrived when I was about 6 months pregnant, and there was no way I was getting in and out of this chair. Okay. So that leads to the conversation about how do different stages of your life and overall ergonomics for the OR. Can I advance? Okay, thank you. So we have a distinguished panel of guests today. They all have the benefit of knowing me. So Dr. Mary Brandt was one of the first individuals to teach me in Houston about surgical ergonomics and positioning. And she is a professor in pediatric surgery at Tulane School of Medicine. And she'll share her experience and what she's learned from a very personal standpoint. Dr. Brian Jones is an associate professor in pediatric surgery at the University of Chicago. And he was the senior fellow when I was in Houston. And we definitely had to do some tweaking of things. So I'll let him share his part. Susan Hallbeck is a PhD researcher at the Mayo Clinic and is this distinguished Robert D. and Patricia E. Kern Scientific Director and Professor of Healthcare Systems Engineering, which I'm sure has an acronym just like everything else at Mayo. She is also the president of the Society of Surgical Ergonomics and the past president of the Human Factors and Ergonomics Society. So she is not able to be here in person, but is able to be by phone for questions. And finally, Dr. Julia Shelton is an assistant professor in pediatric surgery and additionally did a fellowship in surgical education. She currently is at the University of Iowa Stead Family Children's Hospital and has done some programmatic development in surgical ergonomics for the trainees. So I think, we want to not just introduce the problem, but how can we create a solution as well? So I'm going to have Dr. Brandt start.
I see all kinds of faces in here. This is great. So I don't, slides coming up. There we go. Okay. So I was asked to speak about ergonomics from a personal perspective. And this is my outline. This is my bullet points, 2 of them. Why it's an interest of mine, which is going to be my personal story. And then I decided I would just do kind of one of those top 10 lists of the things that I wish somebody had taught me when I was a resident, or that we all probably need to know now. So my story. So this paper was published in 2009, and I actually began my work in ergonomics and in wellness before then. I'm a recovering program director, and what that means is that I took care of a lot of residents and cared about them who struggled in all kinds of ways. And that was really what became the birth of my interest in wellness, was watching people their careers derail for all kinds of reasons. So I was asked to give this lecture. And in the lecture, I talked about exercise. I actually had a table on ergonomics. This is an early paper, I think, in that. And why do I bring this up now? Because this was figure 1 in the paper. And this is my neck. So around age 30, when I was a fellow, I got pain when I operated. And if you look at the data, 80, 90% of us get pain when we operate, right? My neck especially, and I would come home after big cases and tell my wife, I have loop neck, and I would get a neck rub usually after that. But we called it loop neck because it was big cases. At age 42, I started getting some cramping pain in my left arm more than my right. And guys, don't judge me. I was just a moron about this. But anyway, somebody sent me to a physical therapist to fix the trigger point in my shoulder, which was obviously the wrong diagnosis. And the pain didn't go away. So I asked, I ran into one of my orthopedic surgery friends and I said, I've got this trigger point and this pain. And he looked at me and said, how old are you? And I said, I'm 46. He goes, go get an x-ray of your neck. And I was like, okay. So I got an x-ray of my neck and I had a complete collapse. And I got an MRI that basically showed absolutely no CSF around the cord at level C4-5. I saw a neurosurgeon who said, there's really not, you can postpone this if you want to, but if you're the way it looks, if you're in even a minor car accident, you could end up quadriplegic, to which my response was, what are you doing next week? I had an uneventful surgery. Except the episode. So this very prominent hospital, not that long ago, and I'm admitted, and it's actually not painful, by the way. This is not as painful a surgery as you would imagine anterior approach, but I got a little achy, and I said, I'm going to have some morphine to go to sleep. So I called the nurse, and I said, could I have the morphine that I know is ordered? She comes in with a syringe and says, which hip? And I hadn't given IM injections ever. And I said, excuse me? So it turned out the intern that was, I said, call the resident. The intern that was on was the intern on our service the month before and called the neurosurgeon who said, give her what she wants. So I got my pain meds. That was the only time I was a bad patient, by the way. But waking up in the recovery room, and I still have this vivid thing, so I'm coming out of it and I go, my fingers move, my toes move, and I have no pain. And it was one of those things that I didn't realize how much pain I had until it wasn't there. So that's my story, and why I really got interested in this and started teaching more about it, obviously. But here's my top 10 things of what I wish someone had told me. At the number 10 comes in, take care of your feet. Good shoes. That's not Crocs, I'm sorry. And if you're there all day and it's a really long case, you probably need to change your shoes to have a different pressure point. Really good socks. John Wooden, the most famous basketball coach of all time, spent the first week of every season teaching people how to put on socks, because he recognized that if you didn't have that foundation, you would get blisters, you would have problems, and you wouldn't play. Don't skimp. Compression socks. A lot of controversy. Some people love them, some people hate them. They definitely make your legs feel better. So if you like them, please. Pedicures, and guys, don't just bear with me. It is the best thing that you could ever do for yourself. You can find a place you'll feel comfortable. And then standing mats in the OR, which are also a little controversial until you have one. And then there's no controversy about it at all. Number 9, as much as we love them, loops are not our friends. So you really, if you need them, use them. Do not make them your everyday eyewear in the operating room, which a lot of us do. I love this. This is a drawing from JAMA Surgery. Bad, I agree with, but good's not that much better, because you need to get your loops where you have the angle so that your neck does not bend forward that much, okay? Number 8, even if you hate it. Does anyone actually love stretching? I mean, when you get started, it feels good, right? But we all plan our day around that amazing stretching thing we're gonna do? No, I don't think so. So even though we all hate it, stretching is key. And it's about consistency, not quantity. It is not a competition. You don't have to go farther and harder, especially our hamstrings and our pecs, because we live like this and we live like this. You've got to stretch them out. Ideally, you should do every evening before bed, after every case. If nothing else, get in a door jamb and do this to stretch out your chest. During long cases, if you haven't discovered micro breaks and how important they are, lots of data that shows you do better as a surgeon your patient does better, and you feel better. So literally 30-second, 45-second breaks. Mayo Clinic has put out videos that you can play in the OR if you want to, sterile stretching. So why not? Number 7, it's not just the operating room. Ergonomics is not just a work issue, it's a body issue. So anything that puts our head in a forward position is bad ergonomically. If you think about all of the broken chairs and computer screens that don't adjust in our work areas, that's bad too, because we do spend a lot of time at a computer. It needs to be ergonomic. Number 6, there is a big issue with our hands. Well, there's a big issue for those of us that have smaller hands. How about if I say it that way? Solving these ergonomic design issues requires collaboration between manufacturing companies, engineers, and surgeons. This is a little bit later paper, a little naive, a process that's now underway. Not. They don't have any financial incentive to make extra sizes, right? So for those of you that are not blessed with a 6 or 6.5 hand, the instruments are practically impossible to use. And there's all kinds of studies that show that, but it also leads to ergonomic injury. What can you do? If you have small hands, we just need to start advocating. We need every chance we get, every rep, every meeting, everything that's out in the lobbies, we need to tell them. If it's not an issue for you, just be an ally. Do the same thing, bug them. Join the Society of Surgical Ergonomics you just heard about, and they actually have a research thing that's going on right now on hand size that I think is very, very important and good to do. Carrying extra weight is bad. On the front of our heads, loops and headlights, whatever the cost, get the lightest one you can. That's absolutely must. Lead aprons. I don't know about you, but I tend to put them on and I keep them on during the whole case. They actually have those straps on the shoulder so you can take them off in the middle of the case, so we should do that. 2 pieces are better than 1 when it comes to lead aprons because you're fixing weight on your hips as well as your shoulders. And as someone who has struggled with my own weight all my life, being overweight doesn't help. And so if there's any way you can not be overweight, we should try. There is science. There is a whole specialty on occupational health and ergonomics. And we can learn from the people like Dr. Hollebeck that actually do this for a living. So the professionals in occupational health look at postures with 4 categories. 1 is no change. You're doing great. 2 is it's slightly harmful, so don't stay there a long time because it's going to be bad. The 3rd one is distinctly harmful. You need to change this as soon as you can. And then the last one is like, you got minutes. It's just, you don't want to do this. But where do we stand? So if you look, back bent and twisted when static. Both arms raised. It doesn't matter who you are. It doesn't matter how relaxed you are in the operating room. You will end up like this at some point, right? It's just human nature. Our shoulders go up. And then this one in category 3, head bent forward when static or dynamic. So looking down at the wound is a class 3 injury. Number 3, we can mitigate 2 of the 3 things that cause injury in surgery. We can't do much about the frequent repetitive movements. That's surgery, right? But we absolutely can do something about awkward body postures and prolonged static head and back postures. Awkward body postures, the table should be at the height of the tallest person at the table. Doesn't matter if it's a student, the tech, the attending surgeon, there are no exceptions. Okay? Those of you who've heard me talk about this before, when I was program director, we had a chief resident who was vertically challenged. And I walked into the OR one day and he's operating with our 6'4" intern. And the table is set to the height of our vertically challenged chief resident. And the intern looks like this. Okay? And I said, look at you, what is going on here? He goes, well, I'm the chief. And I said, you may be the chief, but you're short. Can we get some standing stools over here? Big faux pas. MIS screens of all kinds, whatever they are, need to be directly in front of the operating surgeon, and the top of the screen needs to be at your eye level, because it's a slightly downward gaze that puts your neck into complete neutral position. So next time you're walking through the OR, walk around and look at the people that are operating like this, okay? Because screens tend to go up and are higher than they need to be. You need to bring them down. We want to keep our weight even on both feet. Okay, I had someone describe this to me as a teaching in Tai Chi, which is called ready to run. And you can imagine what that is. So you're ready to spring forward and take off. You can't be back on your heels or cocked one hip if you're going to do that. The other way it was described to me is imagine you are holding an ant under both heels without crushing it. It's soft knees, balanced weight. Shoulders come up, relax them. Get rid of foot pedals. And if you can't, make sure at least that they're pointed in the direction of the target organ. The other way to take care of this is do an ergonomic timeout. If you know that you're going to be operating deep in the pelvis on a big tumor and it's going to take hours, talk about that in your timeout. You can ask anesthesia to remind you when you get in the flow and you forget how long you've been staring at that one spot, that they can move the table just 5 degrees right and left, up and down. Those 5 degrees will be just enough to change the stress that you're putting on your neck. And again, these micro breaks with posture checks. So I will stop periodically and say, okay, everybody, micro break, posture check. Is your neck neutral? Are your shoulders relaxed? Is your weight even on your feet? Number 2, exercise is prevention. The most effective exercises focus on full rotational strength of all muscle groups, but especially the core. Strength training is key. So all you runners that love running, God bless you. I've just never liked it. It's important for your heart and to relieve stress, but it will not help you in terms of your surgical longevity. It's lifting weights that does that. And again, consistency is more important than achievement. So probably the single best for surgeons is Pilates, yoga, Tai Chi. Those kinds of rotational strength, stretching movements are probably the best for us. You can add planks to your evening stretches and just do it. Do strength training 2 to 3 times a week. Now, I put this one and I realized I forgot actually the other number 1 when I was making these slides. But here's the real, if you remember only one thing today, this is what before I get to the OSHA stuff. Pain equals injury. Okay, this is not working out and getting sore muscles. If your neck and back and hips and knees hurt after an operation, you are injuring joints. Pain equals injury. So something needs to be done to stop that injury. Here's the other number 1. OSHA applies to surgeons too, okay? If you read the law on occupational health, any employee or representative of employee who believe that a violation of a safety or health standard exists that threatens physical harm may request an inspection. Every hospital you work in has an OSHA representative. Now, I'll give you a heads up, it's usually the lawyer for the hospital, but they have a representative. So when you see that in your operating room, you cannot physically get the screen down to the right height, okay, that's a well-established evidence-based recommendation. If you have chairs in front of all the computers that you cannot get in an ergonomic position, ask politely for what you need. Explain why. When it doesn't happen, because we all know how change happens so quickly in all the hospitals, right? Talk to whoever the OSHA representative is. If nothing else, you can request an ergonomic evaluation. They have to provide that. That's part of the law. If it's serious and all else fails, I think we need to take care of ourselves, to take care of our patients. And if we have to do a formal report to OSHA, you may want to pick somebody who, if they fire, is, we're going to say great. No, I didn't mean that. No, pick someone, you don't want to do this in the beginning of your career, I guess is what I'm saying. Pick someone who can take this heat, because there will be heat. But we have to do it. We have to do it for each other, because I think we can change this together. Thanks.
My name is Brian Jones. I want to thank Dr. Klinkner for inviting me here. And I was invited here to talk because I can't see over the podium. So I'm going to go sit over here to give my talk and sort of explain my experiences with being my size and how that's affected my career as a surgeon. So I have a rare form of dwarfism called type 2 geliophysic dysplasia that's characterized by connective tissue disease, short stature, congenital contractures of my hands, and congenital heart disease. I am 4 feet 10 inches or 147 centimeters tall. I had congenital contractures of my proximal interphalangeal joints and had corrective surgery on my right hand when I was 5 years old in order to be able to close my hand. I never got surgery on my left hand, and I cannot make a complete fist with my left hand. And I've just learned to work around that. I wear a size 7 glove because I have very thick proximal interphalangeal joints, but my fingers are quite short. I measured them last night. My index finger is 6 centimeters in length, and my middle finger is 7 centimeters in length. Obviously, the whole time I've been training to be a surgeon, it's been a challenge. Residency was difficult for me because, as Dr. Brandt pointed out, the table height is often set to the height of the most senior person in the room. And so I've always operated on at least 1 step, sometimes 2 steps, and usually sparingly 3 steps. The thing, if you're ever on 3 steps, is to remember you're on 3 steps because it's a lot farther to step down when you're done. So if you have a kind OR nurse, they'll put an extra one behind you so you don't forget after a long case and almost crash down. So far, like, no falls. I had both of my carpal tunnels released when I was a resident. Some thought that that's related to my connective tissue disease, but lost some work time due to that, and was a significant challenge, like, before I even made it to fellowship. When I was a fellow, the cases I found the most challenging from an ergonomic standpoint were bedside cases in the NICU and PICU. For one, I don't know if you've ever had to look for these, but there are a paucity of suitable step stools in all NICUs across the country. It's just hard to find something safe to stand on. Oftentimes when I ask for step stools, there's these nice little wooden angled step stools that are made to be ergonomic for mothers that are holding their kids for kangaroo. But then you stand at about a 25-degree angle. And if you've ever put somebody on ECMO standing on those, you know it's not ideal. Also, the different NICU beds are tough to adjust their height. And so sometimes I was looking over things, looking around things, and that was really tough. The other case that was really challenging for me when I was a fellow was doing a NUS repair for pectus excavatum. The person that did the most of those in my training program had learned to do a retrosternal dissection with his finger. And he has really long hands. And so he says, yeah, you just take off the xiphoid, you put your finger in there, you push the heart out of the way, and then you get it done. And I said, I can't reach the heart. And so we learned to, he let me put the camera in and do more dissection that way, which it's a whole argument about whether you should have a camera anyway. But regardless, we had to change the technique to teach me how to do it because I just couldn't do it the way it was going to be done. As an attending surgeon, I've had to spend a lot of time and energy, learning how to safely and effectively set the room up for myself. And it's been interesting because I don't really have a good mentor for this. There's not a lot of people that have lived it. And fortunately, I've had many years of doing everything else in my life to figure out ways around it, but it does present some unique challenges. I always operate on at least 1 step, even if I'm by myself, because it just feels weird to not be on a step stool. Even if I'm the only person doing anything and I could put the top table all the way down, I just can't do that. I rarely use the foot pedal for anything laparoscopically because trying to balance the foot pedal and me on 1 step stool versus setting up the platform of step stools makes that really challenging. Most cases that I think a lot of people would sit for, pelvic cases, EUAs, I stand for all those. That actually works pretty well for the residents because I let them sit, I stand, and we're like perfectly eye level. And then the other thing is I switch sides of the table a lot. And that was sort of taught to me as dogma that it was something you should not do when I was a resident. Like you need to find your side of the table, set things up and do it. And it's just easier for me to, rather than move the table a lot, is I'll just walk around the other side of the table. So, I'll set the room up where I have my steps on one side and then a spare set of steps. And the OR team knows that they need to clear a path that I can walk around and switch sides if I need to. As far as NUS procedures, the thing that really was a game changer for me was the roll track device. So using that to elevate the sternum really mitigated that need for me to get my finger in there. And then the other thing that was a huge help is they make an extra long handheld bar bender that's really nice. I can't really get my hands around the regular bar bender, and the table bender I found was awkward to use, but there's an extra long handheld bar bender that's been like a total game changer for my pectus practice. Bedside NICU and PICU cases are still an issue. I always go early, not only to make sure the patient's ready and everything's ready, but I spend a lot of time like positioning the patient. I'll often set them a little bit off center, like towards my side, so I can physically reach them. And then I make sure that I have the OR team bring up like proper OR steps. And then I always wear the headlight myself. I don't let the trainees wear the headlight just because I found that too often, like my head would be dipping in the way and my big head would obscure the headlight. So it was a challenge. Laparoscopic pelvic cases are another one that I kind of struggle with. I think I was sort of taught to put the camera in the middle and then the trocars on either lower quadrant and then operate like this. Well, I can't reach my left hand. So what I've taken to doing now is I have the resident drive the camera from one of the low pelvic ones with kind of a side angle. And then I use the umbilical and other trocar to do my work. And then another change that just happened recently at our hospital is they canceled their stapler contract and got a new set of battery operated power staplers that are actually quite hard for me to squeeze because the handle sits farther apart and they're very heavy. And so that has pushed me into not using staplers for my appendectomies anymore, which you could argue I should have done years ago anyway. But that was finally the thing that said, okay, I'm not going to use these stupid staplers anymore because it hurts my hands. So that's kind of where I've been and where I'm going. And as I move forward with my career, just trying to, keep myself safe and learn ways to do this. But thank you to the Benji Brooks Society and Dr. Klinkner for asking me here to speak.
The next portion is the video.
Thank you for having me this afternoon. I'm sorry I wasn't there to be in person. My name is Susan Hallbeck, and I'm a certified professional ergonomist. I'm a professor of healthcare systems engineering at the Mayo Clinic. I have the following financial relationships with Olympus and Intuitive Surgical. I would be remiss as a former president of the Human Factors and Ergonomics Society if I didn't define human factors and ergonomics, which is the application of scientific knowledge about people to the analysis and design of systems so that total system performance is both optimized and human well-being is maintained. In human factors, we have a number of methods. Some of these are subjective, things like the Surgical Task Load Index or NASA Task Load Index, which are workload indices. Surgery degree of difficulty questions, the Nordic questionnaire, which is a body part discomfort survey, and survey instruments for burnout, etc. We also have objective measures, things like the Motion Analysis Lab, which is up in the upper right-hand corner, which is our gold standard with the reflective balls that you see there. We also validated inertial movement units during our Motion Analysis Lab work on some instrumentation. And these are wearable sensors for the neck, back, and shoulders, where we get the percentage of time that you are over rapid upper limb limits, which is risky postures. as well as the percentage of time in static postures. We also record performance metrics like time and errors. Let's start out with looking at surveys, which are subjective for different professional societies, such as plastic surgeons from the American Society of Reconstructive Microscopy, 2 different societies of vascular surgeons, and the European Association of Endoscopic Surgeons. What we found there is that the number 1 pain location is in the neck. This is additionally true of another survey, which was done prior to my joining Mayo Clinic on urogynecologic surgeons. For the vascular and the urogyne surgeons, you see that the lower back is also a high level of pain. As an ergonomist, this next slide is very troubling. About 50% of surgeons fear that their work-related physical discomfort will reduce their ability to perform future surgeries. This is essentially saying they fear for their career longevity. These same surgeons report substantial pain, clinically actionable pain of 4 or higher out of 10. The drivers for this are open surgery, laparoscopic surgery, especially wearing loops, wearing lead, or using a surgical microscope. 60 to 70% of the surgeons in the survey said that they had substantial pain in the past 7 surgical days. This high level of pain is also statistically significantly correlated with burnout for those surveys that we had a burnout question. When we look at objective measures, we use those inertial movement units that we validated in the lab, and we put them on the upper arm, the torso, and the head of surgeons. We then looked at 116 surgeries, over 53 surgeons in 11 different specialties. What we found is that the high or the orange area of risk and the extreme risk was 57% of surgical duration for the neck and 8% in extreme, so 65% total. For torso flexion, we found 30% of its surgical duration that surgeons were in a flex position and 1% in extreme postures. And for the shoulder, for elevation, about 10% of the time in high and 1% in extreme postures. So again, the high-risk neck postures occur in 65% of case duration for the surgeons tested. It's worse for longer surgical durations, and it's worse for open than laparoscopic for the neck. And you can see that that's statistically significantly different in the figure on the right. This is due to using loops and or headlights to look into the field versus looking at a screen in front of you. So I hope that I've convinced you that surgery is a pain in the neck. So what can you do in your operating room? Well, you can start out by looking at surgical ergonomics education and then use the education to set up your OR and think about adjuncts that you're using. And you can also use the OR stretch both intraoperatively and between surgeries. In the Society of Surgical Ergonomics, we created a SCORE curriculum. And at Mayo, we created some educational modules, essentially five-minute short bursts of information that you can use if you wish to by using the QR code on the lower right or the bit.ly. These are free and available for you to use, and they satisfy the SCORE curriculum. In that curriculum, some of the things we suggest is looking at your operative position. Overall, you want relaxed shoulders. You want to have your abduction less than 30 degrees, and that places your upper arm perpendicular to the floor. Your forearm should be about parallel with the floor, and that gives you an included angle of about 90 degrees. Your forearm should also be between supination and pronation. For the neck, keep your flexion less than 30 degrees and the head tilt less than 15, and avoid prolonged static positions, as you often do when you're looking into the surgical field. For your hand, wrist, and fingers, try to keep them in neutral and reduce your extreme excursions to about 30% or less of your operative time. If you're the person doing the retracting, use your larger muscle groups and rotate that task. Specifically for open surgery, when you walk into the room, you should adjust the height of the table for the tallest person, with people on steps for the others. Try to tuck the patient arms to avoid trunk twisting so that you are square on with the table as shown here. And use a headlamp, a light headlamp, and high declination loops so that you end up not having that flexed forward neck posture. Keep the foot pedal, if you use one, near you. For laparoscopic surgery, I can't even tell you how many times I've walked in and seen the monitor near the ceiling. Pull that monitor down so that the top of the screen is at your eye level. An optimal distance is at arm's length. However, that's not very feasible in the operating room. So keep it as close to you as you can. You'll want to make the table height a little bit lower because of the length of the laparoscopic instrumentation, and keep the instruments at about a 60-degree working angle. If you're performing robotic surgery, the first thing you should do is select a chair with good lumbar support and adjustable height, and definitely lockable wheels or casters that you can lock so that you don't end up scooting away from the robot like the figure on the upper right. You should use the armrest and rest your forearm to relax your shoulders. Pull that hood over so that you're looking downward about 30 degrees from horizontal into the viewfinder. And I've also heard for the clutch, ABC, always be clutching, to keep your hands and wrists in neutral, in that sweet spot. When you're talking about adjuncts, use the lightest model available for the least amount of time necessary. Try to consider using high declination loops, which give you less forward neck flexion. Using two-piece lead rested both on the hips and the shoulders, not just the shoulders. And again, use this for the least amount of time necessary. Other measures are to use floor mats. I've heard them called princess pads, but don't let that get in your way of using them. And also don't let infectious disease take them away from you. Use supportive footwear and support codes. Try self-retaining retractors and lighted retractors. Anytime you can, use technology. For example, a bed to prone patients. Sit instead of standing. The pictures of the two chairs here are chairs that you can lean against, but you can also, if you're leaning forward, sit backwards in the chair and put your elbows on the back of the chair. And that gives you some support as well. If you're using the microscope, see if you can get an armrest. And now I want to introduce the OR Stretch web app, which can counteract the OR postures you get in. And it has 1-minute stretches that can be done in the sterile field. It's basically a web app that's a timer with a snooze. And these stretches can be done at any time. The URL is shown here. It is orstretch@mayoclinic.org. The QR code is in the upper left corner. When you use that QR code or go to orstretch.mayoclinic.org, you'll get this login page on the right. If you click on the login button, type in your email in the pop-up box. And the first time you use it, you'll have to satisfy the European Union compliance by clicking on a privacy policy. For most people who've filled out surveys for the OR Stretch, we can see that physical performance, pain and discomfort, and fatigue is greatly reduced, as well as mental focus being enhanced. There are about 3% of people who find that their mental focus is distracted when the harp sound goes off and they're in the middle of something. If this happens to you, you can pause the web app, or if it distracts you too much, you don't have to use it. There are posters as well. Again, here is the web app QR code in the lower left, and this is a picture of the web app, and you can use it for standing surgeries or seated surgeries. The first time you use it, it will come up with 45-minute periods for your timer. You can set the reminder interval between 30 minutes to 2 hours in 15-minute increments. Hit the start button and it will count down. When you get to 45 minutes, there'll be a harp sound that plays and the little red alarm clock will light up, and there'll be a snooze that you can set from 5 minutes to an hour. Then you can hit go to start stretching. If you have somebody coming in to get a pathology sample, or something happens that you need to have somebody go in the core and you need to wait, you don't have to wait for the alarm to go off. You can stretch anytime you have a natural break. If you're having difficulty or there's some problem in the surgery where you need to stop and pause, hit the stop and pause red button there. And then you can come back if you wish to, or you can leave completely. Now I'd like to share with you the OR Stretch web app stretches. And so if you'd stand up, we can go through them together. Are you ready? Here we go.
Stand in base position, feet shoulder width apart. Deep breath in and out. Shrug shoulders up, then back, then down, keeping your chest up. Arms shoulder height, palms facing chest. Reach forward and follow with your shoulders. Return hands to your chest. Flip hands over and reach forward again. Return hands to chest and back to base position. Lift face towards ceiling and drop head back. Breathe in. Now release breath and return to base position. Tuck chin to your chest and continue curling forward. Return to base position. Right foot forward. Look over your right shoulder and continue turning your shoulders. Return to facing forward. Side bend to the left. Return to upright. Left foot forward. Look over your left shoulder and continue turning your shoulders. Return to facing forward. Side bend to the right. Relax and return to the base position. Pinch buttocks together and gently arch your low back. Relax and return to the base position. Pinch buttocks together and do an abdominal crunch. Return to base position. And finish with deep breath in and out.
I hope you enjoyed that. We also have the clean surgery stretches. We have 9 different stretches that can be performed in the surgeon's lounge. And they are something that it doesn't look really obvious that you're stretching. I've demonstrated exercise 1 here, hamstring stretch, and then the trunk rotation with the hip stretch, much like the standing one that you just did. The QR code to get to this is in the upper right-hand corner. I'd also like you to consider giving us some data, again, a QR code for a survey, where we're looking at hand size versus glove size so that we can examine whether glove size is a good proxy for hand size. And we can also measure the hand sizes so that we can talk to manufacturers about things like laparoscopic staplers that are very, very large. Please use your phone as you'll be taking a photograph of your hand. And I want to demonstrate what a 5.5 glove hand looks like with an 8.5 size glove underneath it. Those 2 people use the same instrumentation. I want to thank you again for having me at your conference. And if you have any questions, drop me an email. If you want to go to our website for our lab, the QR code is here. Thank you very much and have a great day. Hello. Thank you for having me this afternoon. I'm sorry I wasn't there to be in person. My name is Susan Hall.
We need to stop that video and go to the next set of slides.
I'm a professor of healthcare systems engineering at the Mayo Clinic. I have the following financial relationships with Olympus and Intuitive Surgical.
Hi. Well, I feel better after that stretch. So I'm Julia Shelton. I am a practicing pediatric surgeon, but also a program director. So I think that's one of the reasons why I was asked to give this talk. So really, I'm giving it from a programmatic standpoint. And we've heard a lot of good reasons to be interested in ergonomics here. But the next step is, what do we do about it? So I've been told, and Dr. Randy also said in her keynote speaker, that we should start everything with a good story. So about 10 years ago, I had the opportunity to go overseas and provide surgical care. And we went with 2 attending surgeons and 2 resident surgeons, pediatricians, 2 anesthetists, and then actually one of the anesthetists' significant other was a physical therapist. And she didn't really have any role in providing clinical care during that week. So instead, she occupied herself by walking around the operating room and just gently readjusting us as we continued to work through the day. It was the best thing ever. It was like getting a massage for 5 days straight. And so one day I found myself standing next to Dr. Geeta Lal, who's also at the University of Iowa and has a love of all things ergonomics, for some similar stories to Dr. Brandt. And I was telling her this story, and she was like, oh, we really need to do this for our residents. And I was like, I completely agree. Do you have any friends? And she said, as a matter of fact, I do. And so she set about rounding up a group of very talented folks at the University of Iowa and elsewhere to essentially plan and set in place a ergonomics curriculum. One of the products of which is the SCORE curriculum that I hope many of you have access to. And so then once we had sort of had a number of meetings and a number of talks, she said, okay, now what? And I said, well, we just do it. And so I think that's one of the other things that you have to find is an accomplice at your institution who will agree to let you have access to your learners in the way that you have set forth. So many of you have seen this. This is a sort of common educational process. This is essentially how you go about making a curriculum. So making an ergonomics curriculum is really no different than any other learning topic. We're just going to focus on ergonomics. So the first thing that you do is you assess needs of the learner. You set goals and objectives. You determine a method of instruction. You create instructional materials, and then you teach your residents. And we'll go through this process in a little bit more detail. So from a needs assessment standpoint, the first thing that you do is you determine who is your learner. So for many of us, that's going to be our pediatric fellow. And I think Brian brought up many key points that we've all had experience in. You know, operating on a tiny 500-gram baby in the NICU is not the easiest ergonomic project. It's not the easiest project in any way, shape, or form, but it definitely has some ergonomic aspects to it. So you need to determine who you're targeting. So for many of us, it's going to be pediatric fellows, but it can be your general surgery residents, it can be your faculty, it can be your OR techs. So I don't know about the rest of you, but my OR techs know that when we're planning a laparoscopic case, they know that the top of the screen needs to be at the operating surgeon's eye line. Sometimes I have to remind them, but they know how to position that, and they should be checking that as part of your patient positioning. So identifying who the learner is the first step, although it's not always the obvious one. And then the next thing you need to do is determine what do they know already. So I think if you talk to your colleagues, you might find that not many of them know about surgical ergonomics. And so you may have to start at the beginning. But understanding what the current level of knowledge is an important first step. And you can do that by sitting around the surgery lounge, talking with your friends. You can do it with surveys. You can do it through feedback. Are any of you in the room program directors? Yes, so you may have recently gotten your ACGME survey back, and there may be some deficits there that you need to meet. And so use that knowledge to your benefit. And then you have to ask yourself, well, what is the goal knowledge? So what are we going to set forth? So for us as, or for myself as the program director at the University of Iowa, our goal was for the general surgery residents to improve their surgical ergonomics understanding and to put that into practice when they were operating. You might have a different one from a different learner standpoint. And then essentially from current knowledge to goal knowledge, that is your gap, and that is what you want to teach. So then you're going to take your needs assessment and you're going to say to yourself, aha, do I have the resource to do this? And the most common problems in terms of resources are money, which we're going to skip. There's a little, exactly. Time and space. So we all know that this is yet another unfunded mandate. Just get over it and do it anyway. Time, many of you are in a position to give time, even if you're just teaching this as a debrief before you start your case in little tiny aliquots. Or if you are a program director, maybe you can set out 1 hour quarterly meetings for your learners in which you go over these topics. But time, money, and space are resources that don't forget to consider as part of your needs assessment. So then you're going to set your goals and objectives. The goal is the overall aspirational topic, right? So the overall outcome that you want to reach. And then your objectives are specific, observable behaviors conveniently that you can measure. And we'll get to that a little bit later. But these are really the directional things that you're going to set out to be part of that. And I've set some examples here. So my goal, again, that I set out was to teach the general surgery residents about surgical ergonomics and to utilize that in their operative practice. Let's transition that to pediatric fellows because that's where we are today. So you might say that your goal is to reduce musculoskeletal injury in our operating pediatric fellows, especially when they're operating in the NICU and in the PICU where they may be outside of support areas that provide ergonomics to them. The objectives that you might set are that the fellows should be able to define common ergonomic concepts. Dr. Halbeck outlined many of those for us in her talk, to select and use appropriate ergonomic concepts in daily operative practice. For instance, Dr. Jones talked about the fact that for the NICU babies, just moving them over toward the side of the bed may significantly improve your ergonomic positioning. And then to prepare ergonomic plans for implementation with their surgical team. So they may teach their surgical OR circulating nurses or techs, or sometimes even your anesthesia team can be convinced to help you with your ergonomic practices. So then you have to outline your actual learning plan. So you've set forth your needs, you've outlined your goals, you've outlined some objectives, and there you're like, now what? There's two basic ways to go about it. One is to use a more esoteric approach and say to yourself, okay, these are my ACGME core competencies. I'm going to kind of pick through each one of these competencies and I'm going to outline a topic that I'm going to address in each one of those. So the most recent example I gave was, teaching your OR nurses to help you arrange your screens. Well, that's interpersonal communication skills, right? The ability of your pediatric surgery fellow to outline and demonstrate and then require that behavior on part of the interdisciplinary team is a great way to teach core competencies in that area. Or you can go to, a different aspect. You can think to yourself, like, what do I need to teach about ergonomics? I need to teach cognitive knowledge. I need to teach technical skills. I need to teach non-technical skills. And then you can just pick one thing from each of those areas to pick. And then you might think about, who am I going to teach that to and how am I going to implement it? I might not want to just dump this on people in one 45-minute session at APSA. I might want to just sprinkle it over the course of a year. What we did at the University of Iowa was first address the need by having Dr. Gita Lal give a grand rounds to our entire medical student, surgery fellows, faculty, to convince people of the importance of paying attention to surgical ergonomics. And in that talk, she outlined our proposed curriculum. And then we just said yes and went and did the curriculum throughout the rest of the year. So that was a way to provide people with knowledge, but also get their engagement. And then in different ways, we taught technical skills. So we would break out our surgical residents, take them to the skills center. Sometimes we even had the ability to incorporate this with a pig lab or a cadaver lab, where we actually have people standing on step stools operating. Someone else is in charge of making sure the screen is right. Someone else is in charge of watching their elbows. So they're not only learning and doing, they're actually also teaching their colleagues and learning how to monitor that over time. And then non-technical skills such as professionalism, leadership, interpersonal communication skills are also taught in these sessions. So a little bit more on methods of instruction and instructional manuals. I covered a little bit of that when I was just talking, but you do want to think about how you actually want to implement and what those materials are going to be. And if you do have access to SCORE, essentially the curriculum that Dr. Lal came up with is available under, I think, the media or the accessory resources under the SCORE tab. But if you go in and you just type in ergonomics, it's the first thing that comes up. So it's a great way to sort of introduce yourself to the topic, if not your faculty and your residents. And then, as I mentioned, when you set out your learning objectives, they should be observable behaviors. So that sets you up very nicely to be able to measure and observe and assess those behaviors. So if you are the attending and your fellow is teaching a junior resident how to do a laparoscopic appendectomy, maybe it's your job to make sure that they have appropriately positioned themselves, the resident, as well as the screens, and you can actually use those for measurements. And when you get one of those forms from your fellow, like, how did I do on the case? In the area where it says comments, you can say appropriately situated ergonomic positioning, blah, 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 blah. Okay, so those specific objectives help achieve the broad learning goals. We've set out how they can help us in different areas. We've given some examples of the NICU. We've given some examples. Another one from the PICU is, you have to turn the bed. The PICU nurses are all freaking out because they don't want to turn the baby who's really sick. But, if you can't reach the baby, you can't put them on ECMO. So it is, the cognitive knowledge and understanding of ergonomically why this is important is the basis for those professional and leadership conversations that we have with our colleagues across the hospital, but just another way to look at it. And as I said, measuring these things and showing that you have programs that you have put in place to assure the wellness and the fitness of your learners and yourselves is important for all of our accrediting bodies. So the fact that you do this when somebody is asking you why, since we don't have any money or time or space, you need to tell them that this is one way in which you can meet requirements for your governing bodies. And it's just a little bit of oomph behind your motivation there. So just to review our educational process and setting a new curriculum forward, we're going to assess needs. We're going to set our clear overarching goal and our observable behaviors in our learning objectives. We're going to determine our methods of instruction. You're going to create instructional materials, and then you're going to go ahead and teach, and hopefully you're going to end up with an educated resident or educated fellow. You're going to consider the environment and resources you need in order to implement those things, and then you're going to assess and use performance evaluations to see how your curriculum is doing. And then it's that feedback process that we see in all other areas, plan, do, study, act. So it's a continual learning and improvement process. And I'm happy to take any questions.
So I want to thank all of our speakers and now open the session up for some questions and let everyone know that Susan Hallbeck is available by phone if there are questions for her as well.
Hey guys, that was great. I don't know, is this all? Shannon Castle, Valley Children's. Has anyone used those like crazy declination, like the reverse fillet glasses loops? So the plastic surgeons at our place are using them, and I'm really tempted to buy a pair. So I was wondering if anyone has.
Yeah, I actually bought them where you look straight ahead and now it freaks out the entire as you walk in, you're looking straight ahead. The difficulty with them is that you still have to stand over because they look straight down. So especially in our babies, so then you have to wait to get them through to the space. But I do found that it helps. You can't do it in anything where you have to turn your head sideways. So I use them for things like that where I want to look straight ahead for ergonomics, not for the loops. But I can't use them for anesthesia or open cases. So I just use them.
Hi, Mark Caton from New Jersey. Thank you for having this session. At my hospital, the infrastructure is very antiquated and nothing comes down on booms, except maybe the lights. So one day I had to pause before starting a case and bring in leadership because I said, between the Bovie and the harmonic and the ligature and the tower and the bear hugger and the IV pull and the IV pull, and I pointed to the table. I said, where do I go? Where do I go? So we were operating sideways for a while. So I wonder from the panel, do you have any knowledge of companies or maybe personal MacGyver type solutions for streamlining all of the carts, stacking, or making things otherwise more narrow that have to come up and are space occupying lesions around the OR table? Thank you.
I don't actually have that, but I will tell you that this is another good example that there are professionals who answer these kind of questions in factories and businesses all the time. And so there is someone in your hospital and every medical school that is designated as someone who will go investigate and write a report on an ergonomic issue and give you suggestions. So that's where I would start. And then, if a little embarrassment is a little incentive, then great.
And Dr. Brandt, is that individual the OSHA person that you were talking about?
They can't not have it. So it may be the OSHA person, it may be the lawyer in the C-suite. So just be aware of that. But I don't think anybody tries to hurt us. So a lot of this is they're just not aware. And if you tell them the story and bring them in, and I do think that goes a long way. I don't think they want to hurt us. They just don't want to spend money to help us, but that's different.
Hi, Leslie Nod from Connecticut Children's. Thank you for all of the resources. I've already shared them with my entire fellowship class and my colleagues at my current position at Connecticut Children's. And I also took a prophylactic physical therapy visit as a fellow to learn exercises to do before I had chronic neck pain. Those are printed and posted in my office. I just have to start using them more regularly. So this was good inspiration. My question is, I don't think there's evidence to say what is the best footwear in the OR, but if there is any, please share. Otherwise, your personal experience and opinions will be greatly appreciated as I look for new footwear in the OR.
I actually wrote a whole post on my blog about it. So it's not going to be cheap. That's the first thing you got to get over, right? This is not sneakers. This is not. So the ones that I have found that are the best is Merrell's. And there's a Merrell clog that's extremely comfortable and you can kick out of the back of it so you can stretch your feet. And then if they get messy, you can throw them in the washing machine. So that's really one of my favorites.
Ron Hirschel, Ann Arbor, wonderful. This is really important. I will tell you that personally, I have a replaced hip and I have my neck is not so hot, as is true of a lot of surgeons. And
or really hot, depending on the day, right?
And it's from years of looking down. I will say that I have really don't understand why with optics we can't have a really good set of loops that we look forward and ergonomically and it looks down. It makes no sense to me. That I did see some prototypes, but what I came in part way, so I apologize if someone's talked about this, but what I really have failed to understand is why we're still using the same OR table that we have used for probably 50 years. Oh, I understand. Yes, but surgeons are really valuable commodities. Not commodities, that's right. Really valuable assets. And commodities is the wrong word. Assets. And to have surgeons actually have physical, problems because of the operating room table. I've often, we have carbon fiber. We could have the ability to sit at the table instead of standing for hours at end, to have each actually go up to the table and be able to work. And I think I would just say that this is a challenge for individuals here who are interested in this area, to get an innovative group to redesign the whole operating paradigm for how we approach patients, I think would be really awesome and quite valuable.
Zaria Morel from Huntsville, Alabama. It's for the PhD that's on the phone. That's my question. So I did an MIS fellowship, and I don't know if anybody knows my past history, but either way, when I did my MIS fellowship, I was sent to France to do a laparoscopic training course. And when I was there, one of the professors, as I was struggling to operate on a pig or whatever we were doing, he says, "You're wasting all this space up here." And he had me flip the handles, and I have been doing that ever since. And it made it easier for me to operate. I didn't know if she was aware of any studies that talk about changing the handle positions to help with ergonomics.
Susan, when you're able to hear that? Susan?
I'm on mute. Sorry about that. I was talking away. Thank you for that question. I don't know of any particular studies on reversing the instrumentation and basically using it upside down. I will say that I've seen a lot of people do that, especially small-handed people, and that gives you a little bit better actuation grasp. But I think that'd be a fantastic study, and I would say that we should be doing that kind of study.
Mike Ishitani, Denise's partner. A
Oh,
question.
you could hear me.
We all get older,
Yes.
and we all think that we look like young fellows in the room, but we're not. And as we get older, you start walking like, what things can we do to try to help ourselves as we get older? Because I had like a very fat head on a very skinny neck, like you do. So what things can we do? Are there back braces, cervical support braces, things like I wear, my kids hate this, I wear Crocs. I used to wear Italian loafers, but now Crocs are wide based and they're very supportive, and I won't trim my ankle when I'm operating wearing Italian loafers anymore. So, suggestion.
Well, there's actually really good data about this, but none of us want to hear it. Exercise, 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 exercise. That's it. Exercise is the preventative thing for successful aging, and it's mostly weight training and stretching.
I think one of the other questions that often comes up is, what do we know about ergonomics in pregnancy? And it's going to be a very short answer, right, Susan?
Totally short answer. No one has studied it, but there is a group out of the Society of Surgical Ergonomics that is trying to set up a study on that. So if people are interested, get in touch with me and we can make it a multi-site study. It's a huge issue because you continue to move away from the table as you become more and more pregnant. And that allows you, that doesn't afford you a way to reach the table very well and puts you in other awkward positions. Plus just the fact of being pregnant changes your ligaments, your tendons. And I heard somebody say that they were recommended to sit down as much as possible. I don't remember who I heard that from because I'm on just headphones. But I think that's another thing that you can do during pregnancy.
All right, I think that concludes our session for today. Thank you for coming, and thanks to our speakers.